welcome back to day 2 of Rhythm Interventions Online 2022. Ladies and gentlemen, it's my greatest pleasure to present a live case session dealing with the topic of concomitant AFib ablation and left atrial appendage closure. And it's a case which will be performed by our friend and one of the pioneers in the field, Claudio Tondo from the Centro Cardiologico Milano. Before we join our case center, I am more than delighted again to welcome our fantastic panel. It is Jason Andrade from Vancouver, Canada. It is Vinit Sawhney from London, UK, and Boris Schmidt, Frankfurt, Germany. So welcome everybody, and I am very much looking forward to what we see and what we will be able to discuss later on. And let's move on without any further delay and join Claudio's lab in Milano.
Hi Julian.
Hi everybody.
Hi everybody. Good evening for the European audience. Good afternoon, or good morning wherever you are, and welcome to Centro Cardiologico today for this live case of concomitant catheter ablation, atrial fibrillation, and occlusion of the left atrial appendage. Let me briefly introduce the team today. We have Gaetano Fossino on my side. Then we have Valentina, our young assistant, and then the nurse team, Lorenzo and Simona. And then we have the technologist, Selena, and 2 engineers for supporting the case, and obviously the anesthesiologist, Claudio, who will be with us for the show tonight. So let me introduce the case today, just to discuss the rationale why to combine 2 procedures in one setting. And can I have the slide for the clinical presentation? So okay, the next slide, please. So this is a man of 67 years old. In 2013, he suffered from a spontaneous cerebral hemorrhage in a patient with hypertension. He had an incomplete healing with residual left hemisoma sensitive and a motor impairment. After a few years, he started to suffer from paroxysmal atrial fibrillation, and after an attempt of external cardioversion, he was put on amio, and NOAC started with anyway unsatisfactory arrhythmia control. So the echocardiogram that you can see, just at the right end of the slide, reveals a mildly dilated left atrium, anyhow a preserved left ventricular ejection fraction, and any other detectable heart disease, especially the valvular dysfunction. Next slide, please. So we might discuss the management options in this kind of presentation. Obviously, we might increase the anti-routine therapy, maybe just adding flecainide or another anti-routine drug to the amiodarone, and keeping the patient on a NOAC therapy. Number 2, we might proceed for PVI isolation and continue with the NOAC therapy, or just to perform a percutaneous appendage closure, or the other option, and this is the option that we elected, just to have the combined PVI isolation and appendage closure. Next slide, please. So the workflow for today is to perform PV isolation by using a cryo balloon, just because the patient has a paroxysmal atrial fibrillation. So we like just to use a one shot platform ablation system. And I think that one of the main advantage today is just to show how to use the ice in the left atrium, just to guide the left atrial appendage closure once we have done with the cryoballoon ablation. The left atrial appendage device occluded sizing will be guided by eyes and angiography. Also, we already have some measurement with a pre-procedural CT scan, and then obviously final check and release. Next slide, please. So let me show just the pre-procedural TE imaging. You can notice, just that was done the day before the procedure. We have the classical windsock shape of the appendage. It's pretty clear the location of the circumflex artery, and the measurement at the TE was roughly 25, 26 the Landon zone, and between 20, 22 the ostium of the appendage. Next slide, please. And here, much closer view. There's no, detectable thrombus formation, no smoke-like effect. Next slide, please. And here we have the CT scan. We have a quite conventional for pulmonary veins. Actually, there is an intermediate branch of the right pulmonary veins, and again we have the windsock shape of the appendage confirmed by the CT scan. Even the with the CT scan we have roughly the same measurement that I mentioned before. Next slide, please. And here we have a really nice left atrial appendage segmentation with a mapping system that was done, just to show the anatomy of the left atrium. It is, a pretty conserved left atrium volume, and in the orange color, the left atrial appendage is shown. Okay, next slide, please. And then we were able just to have a 3D imaging of the left atrial appendage by using a novel software capable to give a much more specific sizing of the device, just based upon an area diameter measurement as opposed to the major diameter of the appendage. This is a software which is intended to overcome some of the problems that we might have with the oversizing the left atrial appendage, and then to avoid any overcompression of the device when we place the occluder into the appendage. So this is what we have done before. Next slide, please. I think probably, and here, based on the sizing that I mentioned earlier, is between 25, 26 the landing zone. So it fits probably around a 31 the size of the occluder, but we'll see. Just later on when we are closer to choose the right size of the pen. But we already know the sizing, and probably we need to confirm with the angio during the procedure, and then we'll go to occlude. Next slide, please. I think probably it is the last slide. So, just for the time's
very
sake,
good, Claudio. Can you just very briefly tell us, is the patient in GA or with sedation? And what would be the next steps? Where are you now? What would we take off from the next steps? And what are we going to see live with you?
Okay. The patient is in deep sedation. Just because we use ice, we don't need just to put the patient on general anesthesia, and this is our workflow, and we started years ago, and then actually basically we don't need the anesthesiology, even though we are fortunate because we are always have an anesthesiologist around in EP lab. But using the ice, I think that it's really very convenient, and then we show you the crossing of the septum with the ice probe as to give you the views in the left atrium of the appendage. So the next step is just to give you what we have done so far, because for the time's sake, if you will. I mean, just we already performed the transeptal, and already I isolated the left superior and the left inferior pulmonary veins. If you let me just show what we have done so far. Here we have the left superior pulmonary vein in the left, oblique projection. There was a, quite a good occlusion, and at the screen, hopefully you can see, I mean, just the baseline recording with the, the circular catheter, and in 35 seconds we have a prolongation, and then we have isolation of the vein, and we achieved a minimum freezing temperature around 62 Celsius degree. Since we have achieved the isolation in 32 seconds, obviously we had just the first application of 180 seconds. And now we are showing the left inferior pulmonary vein. Even in this vein, in 32 seconds, we isolated the vein. And again, we just, give one application of 180 seconds. So if you agree, now we switch, in real time, and Gaetano will move the catheter in the right inferior pulmonary vein,
inflate?
And we inflate the balloon. Try just to pull the circular catheter back as to record some potential. We have some potential over there. And then I think that we are ready just to inject the dye, just to show if we have a...
We see a beautiful spike.
Okay.
And, oh yeah.
A beautiful
this looks
spine.
very good.
I think that
we can go with the
I think we're okay. And then we start, I press the button, and we are ready.
What about phrenic nerve pacing
please?
at this right? Oh yeah, now you do this.
Yeah. As you can see from the screen, we have the diaphragmatic movement, which tell us the entity of diaphragm movement. Even though we like just to have our hands on the belly, because sometimes, I mean, just the value of the feature, I mean, really is not consistent with the reduction of the
no, stop. Okay,
diaphragmatic.
double stop.
I think that
We prefer to stop because we didn't feel phrenic nerve capturing, so we reposition better the. And okay, we have capture. So patient had a movement.
yeah, you
due
moved
to
the
the
patient, but I mean, just
probably some
now,
pain.
I think you were fine.
So we inflate. Okay. All right.
Yeah, I think it was very clear to see that you had some minor dislocation of the pacing catheter from the SVC. Maybe just one word,
right.
And maybe comment. Do you pace from pole 1 to 2, or you pace from pole 1 to 4?
No.
To have a more stable
1 to
catheter?
4.
Any
Yeah.
thoughts on
1 to
this?
4.
1 to 4.
1 to 4. Yeah. I think this is a very
Yeah, we are still a
obvious
very
but
good staining.
valuable
Okay,
Okay.
let's go.
So we can deliver again. Sally pace, please. Okay, we have capture.
Another maybe comment from your side. You brought your spiral catheter very much back in the proximal position. Do you observe any stability issues with this, especially with, let's say, the novel competitor, the novel cry balloon in the arena? Or what are your personal experiences with that device?
Well,
Well, actually, we never had any major issues with
I think we are
with the stability.
close
now
to
we
isolation.
have a prolongation. I think we are close to. Okay, I think we are done. I mean, just this is isolated.
Yeah. Okay.
No, but going back to your question, I think that really, truly, I mean, just the stability is quite good. One of the the issue is, if you need just to pace the phrenic nerve from the beginning, just to avoid any dislocation of the balloon, or just to wait until the freezing temperature maybe is just around between 20 or maybe just less. And we are, now I show you just a very good contraction of the diaphragm. So we are, in a safe position right now. And
if I can,
Very
Julian,
good. Claudio,
if I can add something.
Maybe also involve Jason and ask Jason for his great experience also in looking into dosing, the different, let's say, the time durations. Jason, Claudio and the Milan team is now using 180, I think, as the total duration. What are your clinical, or what is your clinical workflow on that?
So for us, we still use between 180 and 240. It depends a little bit on, the different variability in the tissue depth, depending on the size of the atria you're working. So, when you're on the right side, I think you're balancing risk of phrenic versus efficacy in terms of isolating the veins. And so there's much more benefit with using shorter, less stacked lesions. For the left side, with the depth of the ridge, I'm more worried about reconnection in those areas. So I tend to use a little bit of a longer freeze, and I tend to use empiric repositioning and bonus freezes just to ensure I can get as antral and proximal as possible. And I've done that for both the novel Polar X balloon as well as with the Arctic front.
Right, thank you.
Julian, can you hear me?
Perfectly, yes. We can hear you, yeah?
Okay,
Gaetano,
thank you.
go ahead.
If I can add something, hi. What I like with this technology as compared to the other cryoballoon technology is that when you deliver cryo, let's say you start the cryo, the balloon doesn't change the volume. So I think that this is relevant sometimes when you have positions, especially in the right PVs, where you have to you master this. I mean, some aggressive, let's say, takeoff and curves of the catheter. So I really appreciate this feature as compared to the other competitor.
Okay.
Right.
So I would say, as a devil's advocate, I very much use sort of a proximal seal. So I try to leverage the increased pressure and increased size to go on the freeze a little bit more within the body of the atrium and then engage a little bit afterwards. And so it's a bit of a different workflow approach because if you don't have the pressure advantage of the previous balloon with that change, you can end up deep if you push too hard. So I think your experience allows you to avoid those complications, but it's something I think that is a learning curve coming into the newer experiences with the balloon.
Okay, we
have seen Gaetano and Claudio how you managed to enter the right upper vein, and I may also involve maybe Vinit. We have ice here now also on board. But you did it primary fluoroscopy guided, to my understanding. What is Vinit? We have seen this case from Richard before. He was doing it also with fluoro, but with very gentle, tiny movements, almost zero fluoroscopy. What would you, Vinit, rely more on, fluoro or ice or a combination of both? What is your workflow on this?
Okay.
Well,
so
actually we...
Sorry.
Yeah, go ahead.
We largely rely on fluoroscopy and minimal fluoroscopy. We don't routinely use ice. The vast majority of our cryo cases are done under local anesthetic and minimal nurse-led sedation, so there's not deep sedation at all, besides the, I suppose, cost implications of using ice in every case. I think we've done fairly well in just using X-rays for this. The other point I quite wanted to make, it's really good to rely on perhaps the palpation side of things for phrenic and making sure we're not losing it, but moving a lot away from that and actually looking at the diaphragmatic potentials, which in our experience at BART, certainly we tend to lose sooner before you even feel loss of capture physically by palpating.
So yeah, Vinit is referring to the so-called CMAP, which is more sensitive than just feeling the tummy, of course. That's a very good and important safety point, and I think this is something we all should look into once we do cryoballoon ablation. But let's move back to Milano, and I think Gaetano, you're ready to show us something.
Yeah, we have seen you see the delay on the polar map, but still no isolation.
Maybe you show the
I think
electrograms.
that,
Perfect.
Yeah,
Maybe you can make
this
it
is a
bigger.
rather big vein. Yeah, so in these cases we complete the pulse deliver, the cryo deliver, and then we put the polar map in the intermediate vein just to be able to tilt the balloon and be more complete with the isolation. You see, we had some electrodes are frozen, but you see 3, 4, 4, 5 still with fragmentation and delay, but no isolation. We have not so good temperature, so minus 43, as you can see. You cannot see. Can we show them the cryo
Screen?
temperature and screen? Okay. So not even though I think we had a rather good occlusion. So what I would do, Claude, is complete the 3 minute and then position the polar map in the lower branch, let's say, and get again more in contact with the vein and try to isolate.
Okay,
But I do understand you correctly that even though you did not isolate after 3 minutes or maybe after 150 seconds, you would still complete and go to the final and complete the total 180 seconds. This would be your strategy. And then you would go for repositioning the balloon, I think, right?
Yeah.
Right, yeah.
Because I think that this is the best position for this targeted branch, let's say the main branch of the RSPV. But you see, we still have a conduction. So now we deflate the balloon, and I would go, Claude, in this other lower branch here. I think this is the same. Come
Probably
back,
the
Claude.
same.
Okay, this one.
Okay, this is the other branch.
Yeah.
Maybe just the
Okay.
lower. Let's inflate
inflate?
and let's see what we got from here. Okay.
Okay, let's check if we have a good
Try just to
occlusion.
get some recording and just to pull the.
Yeah.
Okay, try just to get some
Okay.
recording. Now, usually, let's see.
Maybe you can show the ECG a little bigger.
A little, yeah, little.
Okay, I
Wanna
think
do-
that we are selective with this branch, but I think that
You want to
You can
see
do-
the right
yeah.
oblique projection?
okay,
Okay, just go to the right.
to the right.
Just
show also
just
the
see
right.
on the right oblique projection if we have some, because okay, let's
Okay.
see. Let me do the angio
Okay.
again. We have just
Okay.
a small leakage, but I mean just a very good
Yeah, so-
occlusion. Vai a sinistra.
Okay. So I think we can start. You started? Okay.
Okay. So again, you
Okay,
have
we
a
have a
nice
delay.
picture of the phrenic nerve. And we don't see the
Right.
Yeah.
ECG now.
Can you? Okay,
Maybe you
now
can,
now we have it.
You can make it a little bigger, yeah.
Yeah, there's a delay. We are just minus 34, 35 as a freezing.
Yeah, we have small PV potentials, but we can appreciate a little bit of the delay. Now it's freezing there, so let's go on with the pulse.
So just in theory, I agree with you. It looked very spiky, the potential from the right upper vein we have seen before. But in theory, it could also be, or how do you rule out a potential far field situation, typically the right upper vein? Would you recommend to our general audience also maybe to check for potential far field from the SVC, etc.?
Yeah, absolutely. We usually use the quadripolar catheter that we are using for the phrenic nerve pacing. We pull it down to the SVC level, and we make pacing maneuvers just to rule out this. I absolutely agree with you, because we can see from the floor that we are really at the roof of the right atrium almost with the polar map. So probably we may have some far field potential from that structure.
Well, let's,
yeah, temperature is a little bit better than the previous pulse.
If I get it.
46. 180, yeah.
I'm really curious just to see what we have
in the
gone in the
the main branch, let's say.
The main branch and the upper branch. Let's conclude this application.
Yeah, I think it's a very
one trick. Even we have the information from the diaphragm movement. I just, as I told you before, having my hands on the belly, and sometimes I check on the floor, because now we have a, look at 53%, but actually my sensation is, the contraction of the diaphragm is still the same. So one trick actually could be just to position your hand on the left side of the diaphragm and not on the right side. I mean, just because sometimes, just inadvertently, I push too much, and then I have a false positive information from the diaphragm movement. Anyhow, we have done with the second application the
now a little bit of suspense, and we put the polar map in the main branch, and
the main branch we have now toe time around maybe 20 seconds. I mean, just let's see.
Yeah, maybe I use this 20 seconds to ask you another question regarding the tool or the feature from the PolarX console to measure the function of the phrenic, the DMS. What is the role of this in your workflow and your experience?
I don't see any potential from the main. I'm sorry, Julian. Let me check, and then I.
Here we are in the.
First, you go and check your veins, and then we have all the time to come back.
Yeah.
Well, I don't know. I mean, just we. Can you paste from the map? Actually, probably we don't have a capture, but we might achieve. I mean, just isolation the right superior pulmonary vein as well.
Okay, now Sally pace from the quadripolar, and I put this at the level, let's say, of the SVC.
Okay, Gaetano is moving the catheter into the right atrium just to
try to have a little bit more. Okay, so we have a potential which is early as compared to the CS in 6, 7, 7, 8. So definitely I would say that this comes from the right atrium. But anyway, we don't have capture from the vein to the atrium. So I don't think we can.
So what I think that we might have just done with the four pulmonary veins. I mean, any other comment, or do you think that we need to do more? I don't think. I mean, just let's check the left side that. The left side, I mean, just was done, probably just 40 minutes ago, and I think that we don't have any potential in the left superior pulmonary vein.
Would be good if you can see the ECG a little bigger instead of the big fluoro, a bigger ECG.
Okay.
If that would...
Bigger ECG.
Bigger
okay.
ECG, please. I mean, just, can you, okay. Can you see it?
Yeah, it looks,
ECG
we don't see it
bigger and fluoro
bigger, but it
smaller.
looks very flat. It looks flat to me.
Okay,
so,
now.
yeah, now perfect. Yeah,
Okay,
wonderful.
what about now?
Okay, okay.
Yeah,
Okay,
excellent.
this is left
Okay.
inferior pulmonary veins. Okay.
Okay.
If you want to just to see the
Wonderful.
left superior again, just to
If we come back to the left, this is the left superior.
the left superior, I think. Okay. So if you agree, we might switch to the appendage closure right now. And
Absolutely.
what we need, what we need to do is just to cross the septum with the ice probe. Now Gaetano is just moving. What we
maybe we
usually
can
we
go
do
back
this
to the
with the
fluoro. So we have the fluoro. We see the fluoro again.
Yeah. Okay, so
Right now we only see the ECG. Yes, that's good.
okay, we have a fluoro. Okay, okay.
Now we have it. Perfect. Wonderful.
okay, I think we should do this with the guide wire.
Okay. Yeah, maybe just it's better. And
We
just
come back with this one.
Okay, let's do the.
We remove. We put an extra stiff guide wire. We cross the septum with the ice probe, and then we position the dedicated sheath for the.
I think it's much safer. So, I.
Okay.
Okay.
So
it's always
involving
just
our panel while you're crossing the septum, I may also ask again and bring up Jason. What is in your practice? And I mean, you have published beautiful studies, and we learned so much from your recent studies. And also, you could demonstrate that reduction of AFib burden by PV isolation alone can be tremendous. So, do you think that PVI only in a low risk or mid risk CHA2DS2-VASc patient could also play in future a certain role in stroke prevention?
It's an incredible question. I don't know that we have any definitive answers one way or the other. I think the evidence that we're seeing from East AFNet suggests that optimal rhythm management can be very effective at reducing the risk of stroke and reducing the risk of mortality. So, from a rhythm control approach, we should see the benefits. I think that the majority of that rhythm control approach is through the reduction of burden. I cannot tell you that we have any definitive evidence from any randomized studies that ablation reduces the risk of stroke, at least in terms of the studies that have been done. As you alluded to, we did present the results of progressive AF, which was the prolonged follow-up for early AF. And if you look at the adverse events, all of the thromboembolic events were in the drug group, all of the and myocardial infarctions were in the drug group, all of the new onset heart failure were in the drug group. So I think we're getting a signal that earlier intervention with an effective intervention, which is a catheter ablation, may translate out into realizing those long-term benefits. And it may be that the studies previously looking at it were catching people a little bit too far down the curve when kind of the horse has left the barn and the atrium is already quite diseased. So short answer is I don't know that we can definitively say that, but I think it makes mechanistic sense, and we just need to have the studies to prove it.
Right,
Jason,
Boris.
May I? Yeah. So
Boris,
when you say that,
I knew you wanted to jump
congrats.
on this. Jump on the train.
Yeah, congrats to that study first of all. But when you say that that all the, let's say, adverse events were in the drug group, you should also probably state that in the catheter ablation group, the patients did not stop their oral anticoagulation, did they? Or to what proportion did they stop it? Because that, I think that is a different question than can we recommend to stop oral anticoagulation after a successful ablation procedure?
So within our study, no. If you had an indication for anticoagulation, you took it throughout the study. If you did not have an indication for anticoagulation, you took it for at least 2 months after your ablation and then discontinued it. So we did report this in a table in the supplement as well as in the paper. I think about 67% of patients in the study were receiving stroke prevention therapies. I mean, you raise a good point, because if we look at a study like LAOS 3, LAOS 3 did not stop anticoagulation. So their surgical exclusion of the left atrial appendage was an additive 30% reduction in stroke on top of optimal medical therapy or anticoagulation therapy. You know, I would argue that we don't have definitive proof yet that ischemic strokes are reduced by atrial appendage exclusion percutaneously in the absence of continued anticoagulation therapy. So that's another open question that hopefully studies like Champion will tell us in the next couple of years. In terms of the ablation piece, Ocean completed enrollment. This is randomizing patients after successful ablation to continuation or discontinuation of antithrombotic therapy. They're in their long-term follow-up now. I think it'll be about 2 years before we get evidence from an RCT as to whether or not it's safe in patients who have no evidence of recurrence after a year following ablation.
Jason, sorry to interrupt. I think we should go back to Milan, to the lab. And I think Claudio and Gaetano are ready to move on.
Yeah, right.
Yeah, as you were talking, discussing very interesting data and concepts, we crossed the septum with the ice probe. Usually we position this at the really ostium of the left superior pulmonary vein. And by moving it a little bit anteriorly, you can see, you can appreciate sort of long axis image of the appendage with the CFX artery over there with a circle. We are already there with the tip of the long sheath. The measurements we did of the appendage of the landing zone ranges from 2021 to 24, about 24. CT said 28, but probably it was an overestimate of the landing zone.
So, let me just ask you one thing here, Gaetano.
Yeah.
Because we now, of course, apart from the second day, have a different situation. You did ablate with the cryo. Do you think that thermal ablation may also impact potentially by edema the current sizing from today's measurements and therefore explain part of the, let's say, differences? And how would you compensate on that?
This is a very great question. This was our, our decisions 10 years ago or more or less. Choosing, when we decided to combine the procedure, choosing which technology, so point-by-point RF or cryo. And we do not have data, of course, but our impression was that with the cryo, probably you have less edema at the area of the ridge of the appendage itself. And so this could affect less the measurements, as you said. So in our experience, almost all the cases are performed with the cryo. So cryo, PVI with the cryo balloon, and then appendage closure.
Yeah.
A minority of cases we did point-by-point RF.
Yeah, very few cases. I mean, just this was the concern, as Gaetano is pointing out just in the beginning. You know, I think that we have done roughly almost 300, and more procedure, the combined procedure. I mean, and I mean, if I look back, I mean, just our clinical result. I mean, just actually we never had any clinical issues concerning the combined procedure. But there are other experience using RF, and the data are consistent. Very comparable with cryo. Obviously, cryo is faster, or at least it's easier just to use it, and then we are accustomed to have a cryo for paroxysmal. You can ask, even for persistent, what we had done. Well, we try just to stick with PVI when we combine just the two procedures, and we don't like just to have a very long procedure. I mean, just doing other, lesions beyond the PV isolation. So, as we are, talking also, we have shown you the appendage angiogram that we have done just before we went on air. And we have two projection in the right oblique projection, 30 degrees cranial and caudal. Now we are showing you actually the cranial, but more or less, is the same picture, and we have the windsock shape of the pen. So I think that we are, almost ready just to go, because we already discussed the measurement. Now you see, just on the eyes. Can you, put on the screen the eyes, please, right now? We don't need just to the ACG or the intracavity recording right now. We don't care. Can you put the eyes on the screen? We might have the floor on the right and the eyes on the left corner of the screen. Okay, wonderful. Okay, so you see, just the probe into the appendage. So what we are going just to try just to have our device just really farther down. Just as much as we can.
Okay.
Now Gaetano is moving the probe. I want to keep the sheath into the appendage while Gaetano is moving.
We waited to open the device. It's
still discussing the 27 or 31. This is
we believe that since it's a rather long, as you can see, appendage, so we have probably some room to go very distal with the flex ball. We would go with the 31, accepting at least a little bit of shoulder, probably, as compared to the 27.
What do you think?
Boris, what would you
Boris.
select? You have a lot of experience. He's not listening.
Boris still there?
Boris,
or maybe just
can you hear us?
He's too tired.
Probably he cannot hear us.
Boris.
Okay, probably he can't hear us. But I think maybe Jason, he's smiling. Do you want to comment on the size? Or Vinny, do you want to comment on the sizing of the device?
I had more of a question, if I may. Do you routinely use CT scans for all appendage occluder devices? And have you found any major discrepancies between what you find on the day using ISAN or TOE compared to a pre-procedure CT scan? Because that's not something we do routinely at our center for all cases.
Actually, we have a quite a comparable measurement between the pre-procedural CT. We like just to have the pre-procedural CT in all patients, and comparable with the eyes. So I think that we do really rely on eyes, just because it improves the workflow in the lab, as I told you before. And really and truly, I think that there is no major difference between using the TE during the procedure or using eyes. Actually, it's true, and honestly, you have not many views with eyes, maybe just 3 views. This is just the one that we have by positioning the probe in the left superior pulmonary vein. Then we can show you, once we have the device placed into the appendage, the so-called mitral view from below. And then there is another view when we place the probe in the center of the left atrium, and then you can choose the right size of the device even from there. So, but most of the time we rely on this view, like this one that you can see on with the with the probe and the really in the left superior pulmonary vein and the mitral view. So really and truly, I think that there is no major differences between the three different imaging modalities: the CT, the TE, and the ICE.
Yeah,
So,
yes, in fact, beautiful pictures
Gaetano,
from the eyes. And you decided on the device size now?
Yeah, we go for 31.
So Gaetano
31.
is winning.
Yeah.
I mean, the 31. I mean, I was, you know, I mean, just
So
not convinced, but he convinced me. So that let's see. I mean, just and
Probably the trickiest part is to cross this angle. You can see that
can you show just the fluoro?
Before you bring up the device, let me involve our audience and ask the questions you prepared. Q1. So maybe we can see the poll and the audience question, because we wanted, and you wanted to know, what is the main concern about performing concomitant AFib ablation and LAA closure? Is it A, reimbursement, B, potential increased complications, C, length of the procedure, D, training of the EP team, or E, availability of the anesthesiologist? And the audience will vote, and we come back to you. And now we are looking very much forward how the device may fit into the appendage.
Okay. Okay, guys.
Oh yeah, so now you do the ball.
So almost with the ball. I mean, just and
yeah, I think we have to do like this, Claude, a little bit of movement just to lower down the tip and try to go with the ball a little bit more distal. And then I would deliver the device with like this, with a sort of a pushing technique. So sort of coming back a little bit with the sheet and pushing the device
let
out.
me see where you are.
Yeah, we are here.
Okay.
Okay.
Okay. Yeah.
Come back. Okay.
Okay, guys. This is what we. Let me just show you.
Okay, I think the direction, let's say the long axis of the watchman is coaxial with the longest axis of the appendage.
Yeah. I mean, just we can see on the eyes.
So now you can see that
if you
we will measure
the eyes picture a little bit bigger, that would be great.
Yeah, could you put the eyes picture greater? I mean, we can have a, you know, the big screen. I mean, just we need the actual, so we can just remove our, you know, our picture. Who cares? I mean, just everybody.
Okay. Very, very nice.
Okay, very nice.
So usually at this point we measure, as Dr. Mattagliati is doing, the compression of the device itself. So from 31, now we have, let's see what. Okay, we have 20.
We have 20.
A very good compression. You can see that the CFX plane, so the device is well beyond the CFX plane. So at this point, yeah, we have actually it's 22. So
22.
from 31, 22.
I think the compression is good. I mean, can you see?
So at this point, we do the tag test.
Okay.
So if you go.
Okay.
With the floor, Claude, please. We do this kind of gentle traction.
Okay.
Trying to feel that we are attached.
Okay.
Very well attached with the wires. Okay. And then we do contrast, and we check for any leakage with the ice.
Okay.
You
Now,
can see the ice that we are checking for.
That's Dr. Mattagliati, I mean, just our echocardiographer and in the lab is checking with the.
Yeah, what is very nice with this device is that we have.
Can you put ice bigger, please?
Appreciate what you do and check for the leakage, potential leakage, no leakage.
Okay, we have the flow in the left superior pulmonary vein, the upper, left upper corner. Now, I mean, just we are injecting. Okay, that's what we got. I think that's
so
good.
with this device, as you very well know, we don't expect to have an early occlusion of the appendage, let's say. So through the nitinol, the contrast is normal that can pass through the nitinol and go to the appendage itself. But I would say that the position is very nice. We do not have
we don't have a
significant
leakage.
shoulder.
I think that
we check with the mitral.
Yeah, I mean, just let's see if we have a good mitral view from below, so we can show before we release the device. Okay, now.
So with the ice probe, we go in the left ventricle, and I gently rotate everything, and try to see from below. So you can see.
Okay, that's a very nice picture from below.
So with this view, of course, we have the circumflex artery upper, and you can see we do not have a significant shoulder at this point. And the compression of the watchman is, I would say, acceptable.
Okay.
Without any leakage. Okay. So I come back to
playing the ball back to our panel. From the panel, any comments? Do you like the position of the device, Dr. Schmidt, or are would you go for a different position? What are your thoughts? Probably Frankfurt is out of, he can't hear us, so we just see you, okay?
Right.
No I think
so, but still, Jason, go ahead.
I think that,
so again, the limit of this approach is we do not have a multiplanary, multiplane vision, of course. We have two main views, but I think that as a guide for the procedure is satisfactory. So we have a lot of experience with this approach, and so far we have
wonderful.
We have had good results.
I think that we are ready just to release it. What do you think? If you agree, Julian, we go for the releasing.
Yeah, to what I have seen, it looked very stable. I could not identify any relevant leakage, and I think it's a very good position.
Okay, so I mean, let's go for the release. 1, 2, 3, 4, 5. Here we go. Okay.
Okay. You can see that now it's a little bit even more in the plane really of the long axis, let's say, of the appendage. So we check for any effusion.
Yeah,
so
we check
come back
for
to
any
the right.
effusion. So
you can see right ventricle on view. No effusion. Left ventricle.
No effusion.
No effusion here. So
wonderful. Claudio and Gaetano, let us come back now to the next steps for the patient and your patient. We briefly already touched the topic of anti-thrombotic treatment, and you have a bunch of experience using this approach. What would be your standard workflow now?
For the management?
Anti-thrombotic treatment. Yes, post-ablation. Would you just leave DOA? Would you combine with a clopidogrel? Would you go to dual platelet? What would you do?
Well, you know, since we have done a catheter ablation as well, I mean, just I do like, I mean, at least for the first 30 days, just to keep the patient on maybe a small, dosage of a DOAC plus antiplatelet drugs, and then, if the patient is okay, I mean, just we switch to just one single antiplatelet drug. So this is what I would do with this specific patient. But obviously depends on the patient characteristic and the clinical presentation. But what we are going to do is just to keep the patient low dosage of NOAC plus antiplatelet drug.
All right. So
Also
wonderful.
because the patient, yeah.
So maybe we have
chat
the
or-
results back from the
Yeah.
poll and looking
Yeah.
into what came out from your question. And maybe we can see the results. Excellent. So the question was, what was the main concern about concomitant? And with 47%, the risk of course, potential complications. I think this is a very valid taking point. And of course, this could be or is one of the major potential concerns. But I think you have beautifully demonstrated how you can manage and combine LAA closure and on top of pulmonary vein isolation. If this patient now had a recurrence and he had to come back with recurrent atrial fibrillation, do you see any technical problems which need to be considered before going into the second or third procedure?
Sometimes, of course, it happened. Non mi sente.
Okay.
Now we can hear you again. It's
yeah, good question. I mean, okay. Well, you know, we have done obviously redo procedure in some patient with a combined ablation and appendage closure. Really and truly, there's no major concern. Obviously, it depends if you have atrial flutter or atrial tachycardia rising just in close proximity of the appendage. You need just to be very cautious. But most of the time, I mean, just we had gaps in the vein, so I think that we are quite fortunate just to close the gaps, and we never had to do with the device itself. So it's feasible, and I think that it's anyway just quite safe, even the redo procedure.
Very good. Let us also come back and involve our panelists. And we already learned about, of course, the options trial, which is a randomized study looking exactly into the additional value of LA closure on top of PV isolation. And I try for the third time. I promise, if Boris is not listening now, I will not involve him again. Now he smiles. Boris,
no,
what are your thoughts?
He's smiling.
What are your thoughts on the options trial and also looking into going for superiority for, let's say, long-term major bleeding complication reduction? What do you think?
Yeah, first of all, apologies. Obviously, my internet connection struggles a lot. But regarding the options trial, very initially, I was quite skeptical about let's say, the intention to reduce major bleeding complication. However, now my thoughts are a little different. First of all, I think I like the convenience of having a combined approach, and Gaetano and Claudio just elegantly showed how easy that is, or no, not easy, how convenient that is for the patient, and how elegant, and you solve all his problems at one time. I'm very optimistic that the strategy will be non-inferior to an ablation and continuation of NOAC with regards to stroke prevention. I'm very confident. I'm not confident that it is superior, because probably the event rate in the control group is just too low. With regards to bleeding, I'm very, 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 very optimistic that the trial will show superiority in terms of major bleeding reduction with the strategy of adding a device on top of an ablation.
Thank you very much, Boris, for your thoughts on this. And this this close hour has almost finished, and it's now my time to wrap up. First of all, I think we have to congratulate Gaetano and Claudio for this very beautiful and very elegant case, and demonstrating how in a center of excellence, obviously, the combination of closure and AF ablation can be combined. And that was some elegant demonstration on this. Thank you very much on this, and congratulations. Very nice. And I also need to and want to thank Jason, Vinit, and Boris for interacting and discussing this very important, let's say, aspect of AFib treatment for our patients. And by now and for now, I will say goodbye and we'll hand over the Rio second day to Roderick. Roderick Tang, he will host the next sessions. And as I said before, stay tuned. There's even more to come. Stay with us.